So think about when you, like, break your arm, right? You go to the doctor, they take an x-ray, and it shows this very clear, jagged white line.
Yeah, a clean break. It's very obvious.
Exactly. And the orthopedic doctor just, takes a pen, points to the monitor, and says, well, there it is.
Right.
We crave that kind of binary precision in medicine. Like, we desperately want to look at our health through a lens where things are either, perfectly safe or just fundamentally broken.
Oh, absolutely. We want a yes or no answer.
But the moment you bring a new prescription home, and we've all done this, you open your laptop at 2 in the morning, and you look up the side effects.
And that's when the panic sets in.
It really does. That comforting X-ray clarity just immediately shatters into, like, a million terrifying data points.
Yeah.
Suddenly, you aren't looking at a clean break anymore.
Yeah.
You are looking at this absolute avalanche of Latin terminology, statistical probabilities, and just conflicting warnings.
It's overwhelming because, well, we're applying mechanical expectations to, biological and informational chaos. When you look at an X-ray, you're basically looking at structural engineering. A bone is just an object.
A piece of physical material.
Exactly. But when you look at pharmacology, like how a chemical interacts with the incredibly complex, highly individualized ecosystem of your body, binary answers, just cease to exist.
There's no yes or no.
No, it is all about context, probability, and biological trade-offs. The issue is that the internet doesn't really deliver context. It just delivers raw data at this astonishing velocity.
Which brings us to the core mission of this deep dive today. If you're joining us, you probably already know that simply having access to information is, well, not the same thing as actually understanding it.
Far from it.
Right. So today we have a really fascinating source material. We're looking at an excerpt from the iMedix brief.
Yeah, which is super interesting.
It is, because it's trying to figure out exactly why reading a raw drug database usually leaves you feeling way more anxious and confused than before you even picked up the bottle.
Yeah. And this brief details the internal framework of iMedix, which operates as this independent medical information platform.
But just to be clear, we aren't just going to sit here and read a generic summary of their mission statement.
No, that would be boring.
Exactly. We are going to deconstruct the actual mechanics of how an editorial team translates cold, legalistic drug data into practical patient education.
Which is such a necessary skill right now.
And to really ground this, we're going to apply their framework directly to a highly misunderstood case study, which is the medication Propecia.
Oh, man. Propecia is like the perfect case study for this.
Right.
Yeah, because it perfectly illustrates the central problem identified in the brief, which is the massive, sometimes really dangerous gap between a medication's raw data and actual patient comprehension.
I mean, it's a huge gap.
Huge. And the document introduces iMedix by highlighting two very deliberate terms. It states they have an independent editorial and medical research team, and that the platform houses both a drug database and educational resources.
Okay, wait, let's stop right there for a second and look at that word independent.
Sure.
Because I think when people hear, like, independent research, they just think of some guy in a basement with a microscope.
Right, some lone wolf scientist.
Yeah. So what does independence actually mean in the modern landscape of medical information online?
Well, it basically means an absence of structural financial bias. You really have to look at the life cycle of how we usually consume drug information today.
Okay.
On one side of the spectrum, you have pharmaceutical marketing.
Right.
A manufacturer spends billions of dollars developing a drug, navigating all these clinical trials, and securing patents.
Right. They have a massive financial stake.
Exactly. So when they put information out into the world, whether it's, a sponsored search result, a glossy TV commercial, or even their own website, that information is heavily regulated. So it isn't necessarily false, but its underlying architecture is promotional.
It's an ad.
Yeah, it's an ad. It's designed to emphasize the efficacy while satisfying whatever legal liability they have regarding risks.
Right. The goal is to sell the solution while making sure the legal team is happy with the fine print.
Precisely. Now, on the complete opposite side of the spectrum, you have digital content farms.
Oh, like the SEO-driven sites.
Right. The search engine optimization engines, the wellness blogs, the forums. Their currency isn't the sale of the drug. Their currency is your attention.
They just want clicks.
Exactly. They optimize for clicks. And what drives clicks better than anything else?
Fear.
Fear and miraculous claims. So they might take a single, highly anomalous case report of some severe side effect and just blow it up into a massive headline. Because outrage and fear keep you on the page so they can serve you more advertisements.
Wow, so the patient is just caught in this terrible tug of war. Like the manufacturer is pulling them toward the purchase, and the algorithm is pulling them toward the panic.
That's a great way to put it. Yes. So when a platform operates as an independent entity, it acts as a structural buffer. The editorial team doesn't have a financial stake in whether you actually take the medication, nor do they rely on algorithmic panic to sustain their platform.
Their stake is purely in accuracy.
Accuracy in translation. Which leads to the second crucial distinction in the text, the difference between a drug database and an educational resource.
Okay, but I really want to push back on this distinction, though.
Okay, go for it.
Because, I mean, if I am trying to figure out if a drug is safe for me, shouldn't I just want the raw database?
Well,
Like, isn't inserting an editorial team between me and the data inherently a bit paternalistic?
I see what you're saying, but
If a drug causes a specific side effect, just show me the spreadsheet, right? Let me see the numbers. Why do I need an editor to hold my hand?
because it isn't about holding your hand at all. It is about cognitive architecture.
Cognitive architecture.
Yeah, think about it. A database is relational and categorical. It organizes information in columns and rows. So it will tell you adverse event, nausea, frequency, 4.2%. Adverse event, somnolence, frequency, 3.1%.
Okay, just the raw stats.
Right. The data is perfectly accurate, but it is completely devoid of a biological narrative. An educational resource, on the other hand, actually provides that narrative.
What do you mean by biological narrative?
It explains why. It explains that the medication causes nausea because it temporarily alters the pH balance of your stomach acid, and therefore, if you just take it with a piece of toast, that 4.2% probability drops to near zero.
Oh, wow. Okay, that makes total sense. So the database just gives you the inventory of what could happen, but the education tells you the actual mechanics of how it happens.
Exactly.
Like, it's the difference between someone handing you a list of car parts, like steering wheel, transmission, spark plugs,
Yep.
versus handing you a manual on how the internal combustion engine actually works.
That's a perfect analogy.
Right. The list of parts is 100% accurate, but if your engine starts smoking, that spreadsheet is entirely useless. You need to know how they connect.
That is exactly the dynamic. Raw data without an editorial process doesn't answer your actual treatment questions. It just creates noise.
There's a wall of scary words.
Yeah. And when patients are left alone with that noise, we run into the core problem explicitly stated in the source text, which is that people frequently and profoundly misunderstand medication risks.
Let's dig into that psychology, actually.
Yeah.
Because why are we so bad at evaluating risk?
Well,
I mean, we all read the labels, or at least we know the labels are there. Why does a highly educated adult look at a standard medical warning and walk away with a completely distorted view of their own safety?
because our human cognition operates on this evolutionary hardware that is just fundamentally incompatible with modern statistics.
How so?
Think of our risk assessment as an evolutionary smoke detector.
Right.
If our ancestors saw a shadow in the grass, their brain didn't calculate like a 4% probability of a predator versus a 96% probability of the wind.
Right, they didn't do the math.
No. The brain triggered the fight or flight response immediately. We are wired to react to the narrative of a threat, not the statistical mathematical likelihood of it.
So when we look at a drug database, that smoke detector just goes completely haywire.
Completely. Imagine you're scrolling through a raw list of side effects for a really basic medication.
Okay.
The list includes mild headaches, slight fatigue, and then at the very bottom, just buried in the data, it lists a rare cardiac event with an incidence rate of 0.01%.
Wow. 1 in 10,000 people.
Right. Statistically, it is a negligible risk for the average person. But the human brain completely ignores the 0.01% and fixates entirely on the word cardiac.
Heart problems. The smoke detector goes off.
Yes, the narrative of the risk, this terrifying mental image of a heart issue, completely overtakes the mathematical reality. The iMedix text refers to these as real-world patient misunderstandings.
And the real-world consequence is what, exactly?
That a patient might completely abandon a highly necessary, potentially life-saving treatment out of a disproportionate fear of a statistical anomaly.
So they ruin the house to put out a burnt piece of toast.
Exactly.
The raw data spooked them because it lacked context. But does it ever go the other way? Like, do people ever look at the data and underreact?
Oh, all the time.
Really?
Yeah, severe, highly probable warnings are frequently ignored by patients precisely because of how the raw data is formatted.
Wait, how does that work?
Well, if a database uses incredibly dense, polysyllabic medical terminology to describe a serious liver interaction, say, it says something like, concurrent administration may induce severe hepatotoxicity via cytochrome P450 inhibition. The average patient's eyes just glaze over.
I mean, mine just did. It sounds like the terms and conditions for a software update.
Right?
You just mentally click accept and assume the legal department made them put it there?
Right.
You don't think it's an actual threat to your life?
Yes. The presentation of the data is so alienating that the patient assumes it just doesn't apply to them in the real world. So you have this bizarre paradox.
Raw data causes people to panic over negligible risks.
And simultaneously causes them to ignore highly probable dangers. The whole hierarchy of information just collapses.
That's fascinating.
And this is exactly why the iMedix framework dictates that their platform must aggressively avoid turning into a generic drug monograph.
Okay, a drug monograph being that, like, massive, folded-up piece of tissue paper with the tiny font that comes stapled to your pharmacy bag.
Exactly. The dreaded CVS receipt of doom.
Hmm.
The monograph is essentially a legal and regulatory document. It is born out of the FDA approval process.
So it's not meant for me.
No. Its primary function is to exhaustively document every single biological event that occurred during a clinical trial, regardless of whether the drug actually caused it.
Wait, regardless of if the drug caused it?
Yes. If a patient in a clinical trial took a pill and then got hit by a bicycle, technically, trauma has to be recorded in the broader data set.
That is absurd.
It is. The monograph is comprehensive, but it is absolutely not educational.
So how does the platform solve this? The text outlines 3 specific pillars they use to move from a generic monograph to a synthesized education.
Right.
They focus on the medical reasoning behind the issue, who may be affected and why, and the relevant regulatory or warning context.
Let's systematically break those down because this right here is the architecture of medical literacy.
Okay, let's do it.
The first pillar is medical reasoning. As we discussed with the nausea example earlier, it isn't enough to state what a side effect is. You have to explain the biological why.
Right. So if a database says a drug causes dizziness, I might think the drug is somehow, I don't know, poisoning my brain.
Exactly.
But if the editorial team explains the medical reasoning, like maybe the drug is a vasodilator that relaxes my blood vessels, which slightly lowers my blood pressure, meaning if I stand up too quickly, gravity temporarily pulls blood from my head, well, then my entire perception changes. I'm no longer afraid of a chemical curse. I just understand the basic physics of my own circulatory system.
You've replaced anxiety with agency.
Oh, I like that.
Because you understand the mechanism, you know the behavioral intervention, you just stand up more slowly.
Right.
That is the power of medical reasoning. Now, the second pillar is who may be affected and why.
This seems to address the fact that databases treat all humans like identical clones.
Which is the biggest flaw in reading raw medical data. Biological reality is highly, highly variable.
We're not all the same.
No. A generic monograph lists the side effect, but it rarely highlights the demographic nuance. Age, genetic markers, metabolic rates, co-occurring conditions, biological sex, all of these fundamentally alter how a drug behaves in your body.
So it's context again.
Yes. By prioritizing who is affected, an independent platform contextualizes the risk. It tells a healthy 30-year-old whether a specific cardiovascular warning actually applies to them, or if that warning was primarily observed in, say, 80-year-old patients with pre-existing renal failure.
So it filters out the noise that doesn't apply to my specific biology.
Precisely. And then we reach the third pillar, which is relevant regulatory or warning context.
Now, this one is fascinating to me because regulatory warnings, like FDA black box warnings, they feel so absolute.
Right.
Like they feel like a judge slamming a gavel.
They are definitely designed to be authoritative, but they are administrative tools as much as they are medical ones.
What do you mean?
Understanding why a regulator flagged something completely changes how a patient navigates the risk. Was a warning added because the drug is inherently toxic? Or was it added because a very specific rare interaction occurs if the medication is taken alongside a common antibiotic, and the FDA just wanted to ensure doctors don't accidentally prescribe both?
Oh. It's like the difference between someone yelling, the road is closed, versus explaining why it's closed.
Exactly.
Like if I just see a road closed sign, I'm frustrated, I have no idea how long the delay is, and I might try to find some dangerous unmapped detour through the woods.
Yeah.
But if an editorial voice explains the context, saying, hey, the road is closed for 3 hours because a paving crew is laying asphalt, my entire relationship to the problem changes. I know it's a temporary infrastructure issue, not a collapsed bridge. I just wait, or I take the marked detour. The context dictates my behavior.
That is an excellent way to frame it. Context stops the panic and it provides the map. And this three-pillar framework brings us directly to the case study the source text uses as its framing device.
Yes, the deep dive into Propecia.
The document sets up a specific topic for exploration. What is Propecia? And it dictates that the platform must use comparative analysis comparing it with similar drugs or situations to build real understanding.
Now, on the surface, what is Propecia? Sounds like the most simplistic question you could possibly ask.
It really does.
You type it into a search bar, and the raw database gives you a one-sentence answer, right? Like, Propecia is a brand name for finasteride, a 1 milligram oral tablet used to treat male pattern hair loss. Boom. Done. We can all go home.
Right, definition solved. But if we apply the iMedix framework we just discussed, we see that to a medical research team, what is Propecia is absolutely not a request for a dictionary definition.
It's way more than that.
It is an entry point into a massive web of biological mechanisms, very specific demographic restrictions, and incredibly complex safety considerations.
So let's actually do it. Let's run this case study through the editorial pillars right now.
Let's do it.
Pillar 1. The medical reasoning. What is the biological why behind finasteride? How does it actually work? Because a database just says, treats androgenetic alopecia, which means nothing to most people.
Right. To understand the medical reasoning, we really have to look at the endocrine system. The active ingredient in Propecia, which is finasteride, is what is known as a 5-alpha reductase inhibitor.
Okay, let's unpack that right away. What in the world is 5-alpha reductase?
It is an enzyme in your body. Think of enzymes as biological catalysts. They facilitate chemical reactions. In this case, 5-alpha reductase has a very specific job. It takes testosterone, which is a primary male sex hormone, and it converts it into a much more potent androgen called dihydrotestosterone, or DHT for short.
So testosterone meets this enzyme and it gets upgraded into DHT.
Essentially, yes.
So what does DHT do?
Well, DHT is crucial during fetal development and puberty for male physical characteristics. But as men age, DHT has this totally paradoxical effect on hair follicles, depending entirely on where they are located.
Paradoxical how?
On your face, DHT actually stimulates the follicles, promoting beard growth.
Okay.
But on the scalp, specifically at the crown and the vertex, if a man has a genetic predisposition to androgenetic alopecia, DHT is incredibly toxic to the hair follicles.
Wait, toxic? Does it just kill the hair instantly?
No, it's not instant. It causes a gradual process called miniaturization.
Miniaturization.
Yeah. So the hair growth cycle has 3 phases. There's the anagen phase, which is active growth. There's the catagen phase, which is a short transition. And then the telogen phase, which is the resting phase right before the hair sheds.
Right.
What DHT does to these genetically susceptible scalp follicles is it shortens the anagen growth phase and lengthens the telogen resting phase.
So the hair spends way less time growing and much more time resting.
Exactly. And over successive cycles, the hair follicle physically shrinks, it miniaturizes. The hairs become thinner, shorter, and less pigmented until eventually the follicle just stops producing hair altogether.
Wow. So the medical reasoning behind Propecia is actually quite elegant then.
Very much so. Finasteride enters the body and physically binds to the 5-alpha reductase enzyme. It essentially blocks the lock so testosterone can't insert itself.
So the conversion stops.
Yes. This drastically reduces the amount of DHT circulating in the scalp, usually by about 60 to 70%.
By lowering the DHT, you remove the toxic variable,
Right.
stopping the miniaturization process, and allowing the follicle to just return to its normal growth cycle.
That's it. That's the mechanism.
That makes complete sense. But understanding that biological mechanism leads us directly to the second pillar. Who may be affected and why? Because this is all about blocking a male hormone conversion, this drug must have massive demographic specificity.
It absolutely does. And this is exactly where a generic monograph can be incredibly misleading if you don't really understand the who. Propecia is exclusively indicated for men with androgenetic alopecia.
Just men.
Just men. It is not for women, and it is certainly not for children.
Okay, so why is it contraindicated for women? Is it just ineffective for female hair loss, or is it actually dangerous?
In premenopausal women, particularly those who are pregnant or may become pregnant, finasteride presents a severe regulatory and safety risk, which actually ties perfectly into our third pillar.
The regulatory context.
Right, because finasteride blocks the conversion of testosterone to DHT, and because DHT is absolutely essential for the normal development of male genitalia in a fetus, exposure to finasteride during pregnancy can cause severe birth defects.
Oh, wow.
Specifically, it can cause ambiguous genitalia in a male fetus.
That is a massive, massive safety consideration. And it's not just about, like, a pregnant woman taking the pill, right?
Hmm.
The warnings get incredibly specific about even handling the medication.
Yes, very specific. The regulatory warning context is extremely strict here. Pregnant women are advised not to even touch crushed or broken finasteride tablets.
Wait, really? Just touching it?
Yes, the medication has a special coating on it, but if that coating is compromised, like if the pill is crushed, the active ingredient can be absorbed directly through the skin.
See, this is exactly what we were talking about with the road closed analogy.
Yeah.
If a woman reads a database that just says, contraindicated in females, do not touch crushed pills, it sounds like some bizarre, arbitrary rule. It sounds like a legal technicality to avoid a lawsuit.
Absolutely.
But the moment you provide the medical reasoning that the drug inhibits the exact enzyme required for a male fetus to develop properly, the warning transforms from a confusing legal mandate into an utterly logical biological imperative.
Exactly. The narrative clarifies the risk. You don't have to guess why the rule exists.
Right.
And we see this exact same need for clarification heavily when we look at the side effect profile for men actually taking the drug. Because when men look up Propecia, the side effects that immediately trigger that evolutionary smoke detector are the sexual side effects.
Oh, yeah. Decreased libido, erectile dysfunction,
Yeah.
ejaculation disorders. I mean, for a lot of men, seeing those words on a screen is just an immediate deal breaker. They see the raw data and panic.
It's very common.
So how does an editorial framework handle a risk that is so emotionally charged without, just burying the truth?
By contextualizing the statistics and the mechanism, the generic monograph will simply list those adverse events as possibilities, but an educational resource will break down the actual clinical trial data.
What does the data say?
It will explain that, yes, these side effects are real, but they typically occur in a very small percentage of men, usually around 1 to 2%.
Just 1 to 2%.
Yes. Furthermore, it will explain the biological reality that the endocrine system is highly adaptive. For many men who do experience these side effects, the symptoms often resolve either as their body adjusts to the medication over a few months, or they resolve completely upon discontinuing the drug.
Okay, but wait, I have to challenge that.
Go ahead.
Because if you look at the forums, like if you step outside the clinical data and into the digital noise of the internet, you see men claiming permanent sexual dysfunction long after they stop taking it, like years later.
Right. You are referring to what is sometimes called post-finasteride syndrome, or PFS.
Yes, that's it.
And this is exactly where independent medical research teams really earn their keep. They have to navigate this very tricky space between a rigorous clinical data and anecdotal patient reports.
Right, because you can't just ignore the patients.
Exactly. The editorial framework must acknowledge that while the vast majority of side effects resolve upon discontinuation, there are persistent reports of long-term issues regarding sexual function and mood.
Mood issues, too,
Like depression and severe anxiety. And this is likely linked to the role 5-alpha reductase plays in synthesizing certain neurosteroids in the brain, not just DHT in the scalp.
Oh, so the enzyme does other things, too.
Yes. So the platform's job isn't to dismiss those patient reports, nor is it to amplify them into a massive panic. The job is to present the current state of the scientific consensus.
Which is what?
That the risk of permanent dysfunction appears exceedingly rare, but the exact mechanism behind it remains under active scientific investigation.
So they give the patient the actual tools to weigh a 1 to 2% acute risk against the subjective value of preserving their hair. It's about informed consent, not just blind reassurance.
Precisely. You give them the full picture.
Yeah.
Now, there is another massive safety consideration with finasteride that highlights the absolute necessity of patient education, and it involves prostate cancer screening.
Wait, how does a hair loss pill interact with prostate cancer? Those seem entirely unrelated.
This requires a look at another form of finasteride, and this is where the source text dictates that we must use comparative analysis comparing the topic with similar drugs or situations.
Okay.
So this is where we have to discuss a drug called Proscar.
Proscar, which is the exact same chemical as Propecia, right? It's just finasteride.
It is the exact same active ingredient, yes, but at a vastly different dosage.
How different?
Well, Propecia is 1 milligram of finasteride, optimized for hair loss. Proscar is 5 milligrams of finasteride, and it is used to treat BPH, benign prostatic hyperplasia, which is an enlarged prostate.
Oh, because DHT also stimulates prostate growth.
Exactly.
So by blocking the DHT with a much larger dose, you shrink the prostate. That's clever.
It is. But here is where the critical safety interaction occurs. When doctors screen men for prostate cancer, They use a blood test called the PSA test, prostate-specific antigen.
Right, I've heard of that.
Elevated PSA levels can be a biomarker for prostate cancer. But because finasteride shrinks prostate tissue, taking finasteride artificially lowers your PSA levels by roughly 50%.
Oh, wow. Wait, so if a man is taking Propecia just for his hair, and he goes in for a routine cancer screening, his test results are going to look artificially healthy.
Exactly. If his true PSA level is, say, a 4.0, which might trigger a doctor to order a biopsy, the finasteride will make it look like a 2.0.
So it's normal.
Right. And if the doctor doesn't know the patient is taking finasteride, they will misinterpret the data, and they could entirely miss an early diagnosis of prostate cancer.
That is terrifying.
It really is.
And that is the ultimate proof of why a raw drug database is insufficient. Like if a 35-year-old guy buys finasteride online through some telehealth portal and just reads a generic summary, he might have no idea that decades later this little hair pill is going to completely skew his cancer screenings.
None at all.
An editorial platform has to connect those dots. They have to explicitly tell the patient, you must inform your urologist that you take this, so they can literally double your PSA score to get an accurate baseline.
The database provides the chemical interaction. The education prevents the real-world medical error.
Wow. This comparative analysis rule from the source text comparing it to similar situations is so useful. But let me ask you this. If we compare Propecia to other hair loss treatments, how does that help the patient? Doesn't bringing in other drugs just muddy the waters?
Not if it's done right. It actually organizes the mental map.
How so?
When you try to understand a new concept in a total vacuum, you have no hooks to hang the information on. By contrasting Propecia with the other massive player in the space, minoxidil, which most people know is Rogaine, you actually clarify the biological expectations.
Right, because minoxidil is over the counter, whereas finasteride requires a prescription. Why is there a difference?
Because the mechanisms and the medical reasoning we talked about are entirely different. We established that finasteride is a systemic hormonal modifier.
Right, it blocks the enzyme.
Exactly. It alters DHT levels throughout your entire body. That carries systemic risks, hence the prescription. Minoxidil, on the other hand, is a topical vasodilator.
You just rub it on your head.
You apply it directly to the scalp. It doesn't block DHT at all. It simply widens the blood vessels around the follicle, increasing blood flow, oxygen, and nutrient delivery to prolong that anagen growth phase we talked about.
Oh, I see. So finasteride basically plays defense by blocking the toxic DHT, and minoxidil plays offense by flooding the follicle with nutrients.
That's a brilliant way to put it. Yes. And by understanding that contrast, the platform corrects one of the absolute most common patient misconceptions: the timeline and the permanence of the treatment.
Right. What are the realistic expectations here? Because we live in an era of like overnight shipping and instant downloads. If I take a pill, I expect my headache to be gone in 20 minutes.
Of course. And if you apply that mechanical expectation to hair loss, you will abandon the treatment within a month.
Because nothing happens.
Right. Biological synthesis takes time. Because finasteride is simply altering the hormonal environment to allow the natural hair cycle to recover, it takes an absolute minimum of 3 to 6 months of continuous daily use before you even see a stabilization of hair loss.
3 to 6 months just to stop losing it.
Yes, and often up to a full year to see any noticeable regrowth.
Because you have to wait for the miniaturized hair to fall out, rest, and then slowly rebuild a healthier follicle over months and months.
Yes. Sometimes people even experience a shedding phase at the beginning, which freaks them out, but it's just the old hairs making way for the new ones.
Okay, so patience is key.
Huge. And more importantly, you really have to understand the maintenance therapy requirement. A generic database might not emphasize this clearly enough. Finasteride is a treatment, not a cure.
Right. The biological reality is that your genetics haven't changed.
Exactly. Your body still genetically wants to produce that 5-alpha reductase enzyme.
So if you stop taking the pill,
the enzyme immediately resumes converting testosterone into DHT. The DHT floods right back into the scalp, and the miniaturization process starts all over again.
So you lose it all again.
Within 6 to 12 months of stopping the medication, you will lose any hair you managed to preserve or regrow.
So you are basically renting the hair, not buying it.
That is a very accurate, if blunt, way to put it.
Yes.
You are committing to a lifelong pharmacological intervention to maintain the aesthetic result.
Wow. So just synthesizing everything we've just done here.
Yeah.
We took that incredibly simple question, what is Propecia?
Yeah.
And we saw that to answer it safely, an editorial team has to cover enzyme mechanics,
Yep.
fetal development risks, the psychology of sexual side effects, the mathematics of prostate cancer screenings, and the behavioral economics of long-term maintenance therapy.
And that comprehensive mapping is the only way to counteract the digital noise.
It really is.
It isolates the variables. You stop seeing the drug as this mysterious, standalone entity with a terrifying list of warnings, and you start seeing it as a specific biological tool with clear rules of engagement.
This has fundamentally changed how I view the information I consume. I mean, we started today looking at a brief from an independent medical platform, iMedix, and we unpacked a massive systemic vulnerability in modern healthcare.
A huge one.
We realized that just having access to medical data is not a privilege if that data is completely unstructured. It is just a liability. We learned that true medication safety relies entirely on editorial teams doing the heavy lifting, translating that generic drug monograph into an actual educational narrative, breaking down the biological mechanisms, demographic realities, and regulatory contexts.
It is truly the only way we can bridge the gap between chemical data and human understanding.
But as we close this out, there is a looming reality we have to acknowledge.
Yeah.
We have established that the difference between safe medical treatment and dangerous misunderstanding comes down to how information is meticulously and humanely edited and contextualized.
Right.
We need that human insight to turn off the evolutionary smoke detector.
Right.
But we are rapidly entering an era where artificial intelligence engines and large language models are auto-generating our medical answers.
Which is moving so fast.
So fast. And these systems are incredibly fast at scraping those raw, generic drug databases, but they often lack that deliberate human editorial oversight to weigh the narrative risk. So the question we want you to mull over as you go about your day is this. In an automated digital era, are our real-world patient misunderstandings about to get remarkably better because of instant access, or profoundly more dangerous because we removed the editor from the room?
That is a critical question for the next decade of healthcare.
Think about where your information is coming from and who or what is doing the filtering. Thank you for joining us on this deep dive. Remember to keep asking those big questions, demand the underlying context, and never settle for the generic answer.